What is OCD? Obsessive-compulsive disorder (OCD) is a mental disorder in which a person has certain thoughts repeatedly, called obsessions, or feels the need to perform certain routines repeatedly, called compulsions, to an extent which generates distress, or impairs general functioning. The person is unable to control either the thoughts or activities for more than a short period of time. Common compulsions include hand-washing, counting of things, and checking to see if a door is locked. These activities occur to such a degree that the person's daily life is negatively affected, often taking up more than an hour a day. Most adults realize that the behaviors do not make sense. The condition is associated with tics, anxiety disorder, and an increased risk of suicide. The cause is unknown. There appear to be some genetic components, with both identical twins more often affected than both non-identical twins. Risk factors include a history of child abuse, or another stress-inducing event. Some cases have been documented to occur following infections. The diagnosis is based on the symptoms, and requires ruling out other drug-related or medical causes. Rating scales such as the Yale-Brown Obsessive-Compulsive Scale (YBOCS) can be used to assess the severity. Other disorders with similar symptoms include anxiety disorder, major depressive disorder, eating disorders, tic disorders, and obsessive-compulsive personality disorder. Treatment involves psychotherapy, such as cognitive behavioral therapy (CBT), and sometimes antidepressants, such as selective serotonin reuptake inhibitors (SSRIs) or clomipramine. CBT for OCD involves increasing exposure to what causes the problems while not allowing the repetitive behavior to occur. Contrary to this, metacognitive therapy encourages the ritual behaviors as to alter the relationship to one's thoughts about them. While clomipramine appears to work as well as SSRIs, it has greater side effects, and thus is typically reserved as a second-line treatment. Atypical antipsychotics may be useful when used in addition to an SSRI in treatment-resistant cases, but are also associated with an increased risk of side effects. Without treatment, the condition often lasts decades. Obsessive-compulsive disorder affects about 2.3% of people at some point in their lives, while rates during any given year are about 1.2%. It is unusual for symptoms to begin after the age of 35, and half of people develop problems before 20. Males and females are affected about equally, and it occurs worldwide. The phrase obsessive-compulsive is sometimes used in an informal manner unrelated to OCD to describe someone as being excessively meticulous, perfectionistic, absorbed, or otherwise fixated. OCD signs and symptoms. OCD can present with a wide variety of symptoms. Certain groups of symptoms usually occur together. These groups are sometimes viewed as dimensions or clusters that may reflect an underlying process. The standard assessment tool for OCD, the Yale-Brown Obsessive-Compulsive Scale (YBOCS), has 13 predefined categories of symptoms. These symptoms fit into 3 to 5 groupings. A meta-analytic review of symptom structures found a 4-factor structure grouping to be most reliable. The observed groups included a symmetry factor, a forbidden thoughts factor, a cleaning factor, and a hoarding factor. The symmetry factor correlated highly with obsessions, related to ordering, counting, and symmetry, as well as repeating compulsions. The forbidden thoughts factor correlated highly with intrusive and distressing thoughts of a violent, religious, or sexual nature. The cleaning factor correlated highly with obsessions about contamination, and compulsions related to cleaning. The hoarding factor only involved hoarding-related obsessions and compulsions, and was identified as being distinct from other symptom groupings. While OCD has been considered a homogeneous disorder from a neuropsychological perspective, many of the putative neuropsychological deficits may be due to comorbid disorders. Furthermore, some subtypes have been associated with improvement in performance on certain tasks such as pattern recognition, washing subtype, and spatial working memory obsessive thought subtype. Subgroups have also been distinguished by neuroimaging findings and treatment response. Neuroimaging studies on this have been too few, and the subtypes examined have differed too much to draw any conclusions. On the other hand, subtype-dependent treatment response has been studied, and the hoarding subtype has consistently responded least to treatment. Obsessions. Obsessions are thoughts that recur and persist, despite efforts to ignore or confront them. People with OCD frequently perform tasks, or compulsions, to seek relief from obsession-related anxiety. Within and among individuals, the initial obsessions, or intrusive thoughts, vary in their clarity and vividness. A relatively vague obsession could involve a general sense of disarray or tension accompanied by a belief that life cannot proceed as normal while the imbalance remains. A more intense obsession could be a preoccupation with the thought or image of someone close to them dying, or intrusions related to relationship rightness. Other obsessions concern the possibility that someone or something, other than oneself, such as God, the devil, or disease, will harm either the person with OCD or the people or things that the person cares about. Other individuals with OCD may experience the sensation of invisible protrusions emanating from their bodies, or have the feeling that inanimate objects are ensouled. Some people with OCD experience sexual obsessions that may involve intrusive thoughts or images of kissing, touching, fondling, oral sex, anal sex, intercourse, incest, and rape with strangers, acquaintances, parents, children, family members, friends, co-workers, animals, and religious figures, and can include heterosexual or homosexual content with persons of any age. As with other intrusive, unpleasant thoughts or images, some disquieting sexual thoughts at times are normal, but people with OCD may attach extraordinary significance to the thoughts. For example, obsessive fears about sexual orientation can appear to the person with OCD, and even to those around them, as a crisis of sexual identity. Furthermore, the doubt that accompanies OCD leads to uncertainty regarding whether one might act on the troubling thoughts, resulting in self-criticism or self-loathing. Most people with OCD understand that their notions do not correspond with reality, however, they feel that they must act as though their notions are correct. For example, an individual who engages in compulsive hoarding might be inclined to treat inorganic matter as if it had the sentience or rights of living organisms, while accepting that such behavior is irrational on a more intellectual level. There is a debate as to whether or not hoarding should be considered with other OCD symptoms. OCD sometimes manifests without overt compulsions, referred to as primarily obsessional OCD. OCD without overt compulsions could, by one estimate, characterize as many as 50% to 60% of OCD cases. Compulsions. Some people with OCD perform compulsive rituals, because they feel they have to, while others act compulsively so as to mitigate the anxiety that stems from obsessive thoughts. The person might feel that these actions somehow either will prevent a dreaded event from occurring, or will push the event from their thoughts. In any case, the individual's reasoning is so idiosyncratic, or distorted that it results in significant distress for the individual with OCD, or for those around them. Excessive skin picking, hair pulling, nail biting, and other body-focused repetitive behavior disorders are all on the obsessive-compulsive spectrum. Some individuals with OCD are aware that their behaviors are not rational, but feel compelled to follow through with them to fend off feelings of panic or dread. Some common compulsions include cleaning, checking things, for example locks on doors, repeating actions like turning on and off switches, ordering items in a certain way, and requesting reassurance. Compulsions are different from tics, such as rubbing, or blinking, and stereotype movements, such as head banging or self-biting, which usually are not as complex, and are not precipitated by obsessions. It can sometimes be difficult to tell the difference between compulsions and complex tics. About 10% to 40% of individuals with OCD also have a lifetime tic disorder. People rely on compulsions as an escape from their obsessive thoughts. However, they are aware that the relief is only temporary, that the intrusive thoughts will soon return. Some people use compulsions to avoid situations that may trigger their obsessions. Although some people do certain things over and over again, they do not necessarily perform these actions compulsively. For example, bedtime routines, learning a new skill, and religious practices are not compulsions. Whether or not behaviors are compulsions or mere habit, depends on the context in which the behaviors are performed. For example, arranging and ordering books for 8 hours a day would be expected of one who works in a library, but would seem abnormal in other situations. In other words, habits tend to bring efficiency to one's life, while compulsions tend to disrupt it. In addition to the anxiety and fear that typically accompanies OCD, sufferers may spend hours performing such compulsions every day. In such situations, it can be hard for the person to fulfill their work, family, or social roles. In some cases, these behaviors can also cause adverse physical symptoms. For example, people who obsessively wash their hands with antibacterial soap and hot water can make their skin red and raw with dermatitis. People with OCD can use rationalizations to explain their behavior. However, these rationalizations do not apply to the overall behavior, but to each instance individually. For example, a person compulsively checking the front door may argue that the time taken, and stress caused by one more check of the front door is much less than the time and stress associated with being robbed, and thus checking is the better option. In practice, after that check, the person is still not sure and deems it is still better to perform one more check, and this reasoning can continue for as long as necessary. In cognitive behavioral therapy, OCD patients are asked to overcome intrusive thoughts by not doing any compulsions. They are taught that rituals keep OCD strong, while not performing them causes the OCD to become weaker. Thanks for watching our video. Make sure you subscribe to receive more video related to OCD treatment, and many other everyday health and wellness. Don't forget to leave a comment, hit the like button, and share our video. Thank you so much for watching. Be safe, and stay healthy.